Good wishes, everybody. I am Professor Dr. Aravinda Jagdisha from Bangalore, which is in the south part of India. Greetings to all of you from India. So, first of all, I like to thank Professor Nosey Yusuf and the whole team for inviting me and making me a part of this International Annual Congress of Egyptian Cardio-Diabetic Association. I wholeheartedly wish this eighth annual conference. I wish all the success. So now I'll go to my topic. I'll share my slide. So this is my presentation. I'll be talking on this particular topic. What causes beta cell dysfunction in diabetes? This is an interesting topic to discuss. So this is me. I'm MD MRCP from London, UK. I used to work in London for 5 years. Then I finished that triple FRCP from Edinburgh, London, and Glasgow. Currently, I'm the chairman and chief diabetologist of Dr. Aravinda Diabetes Center in Bangalore, that is south of India. So this is my recognition. I am elected as an vice president of National RSSDI, that is the Diabetic Association of India. So greetings to all of you from Bangalore. So going to the topic proper, we know the beta cell physiology, the pancreas, we know the pancreas, the common bile duct, endocrine tissue, exocrine tissue, pancreatic ducts, how it is there. And we know islet cells, that is alpha cell, beta cells, and delta cells. The beta cells you can see there, how the beta cells is marked in the red. So the amount of insulin released depends on both the absolute number of beta cells in the islands of Langerhans cells, that is the beta cell mass, and the output of each of these cells, that is the beta cell function. So the beta cells of the pancreas make, store, and secrete insulin. We can see from the left hand side, that is the pancreas, what we are seeing, and which is, we can see, if we take the center, that is the endocrine portion, we have alpha cells which secretes the glucagon, beta cells secretes insulin, delta cells secrete somatostatin, F cells secrete pancreatic polypeptide, and exocrine mass, that is acinar cells and the duct cells. So beta cells are located in the endocrine portion of the pancreas. In the normal human adult pancreas, beta cell mass amounts to less than 2% of pancreatic weight. So, pancreas typically weigh between 60 grams and 100 grams. So, beta cell mass is somewhere near 1 to 2 grams. So, beta cells make, store, and secrete insulin in response to nutrient intake. So in this slide, you can see the beta cell mass is maintained through a delicate balance between cell loss and cell regeneration. Whether beta cell regeneration occurs by replication of pre-existing beta cells or by neogenesis from a non-beta cell pancreas precursor is a major focus of interest. On the left hand side, you can see the beta cell regeneration aspect, which involves replication, neogenesis, and hypertrophy, leading to beta cell mass dynamics. On the right hand side, you can see the beta cell loss because of cell death, that is apoptosis, and beta cell dedifferentiation. So, if you take the beta cell physiology, under the physiological condition, the maintenance of blood glucose concentration within a narrow physiological range relies on coordinated regulations of insulin secretion through nutrient availability, hormones, and neural inputs. Normoglycemia is maintained under a balance between insulin sensitivity and insulin secretion. And when insulin sensitivity decreases, insulin secretion increases to maintain normoglycemia. So, glucose is by far the most potent and physiologically important regulator of beta cell function through coordinated stimulation of insulin gene transcription, pro-insulin biosynthesis, and insulin secretions from beta cells. You can see the why does the beta cell dysfunction occurs. It results from an inadequate glucose sensing to stimulate insulin secretion, therefore elevated glucose concentration. Persistently elevated glucose concentration above the physiological range results in the manifestation of hyperglycemia. On the right hand side, you can see the environmental factors. So normal beta cell genes, you can see normal beta cell function, compensatory hyperinsulinemia, and normoglycemia. In the middle, you can see the obesity and insulin resistance genes leading on to obesity, leading on to insulin resistance. And the abnormal beta cell genes leads to reduced beta cell function, decreased insulin secretion, and leading on to type 2 diabetes. You can see this slide, very busy slide, but does very simply to explain a chronic load on the beta cells may lead to severe dysfunction such that histologically normal beta cells fail to secrete insulin properly in response to glucose. So, beta cell dysfunction is an early event in the natural history of type 2 diabetes. Its progression is variable and potentially influenced by several clinical factors. You can see in this slide there are stages of beta cell function. There are 5 stages. On the right hand side, starting, you can see the stage 1 is the compensation. Stage 2 is stable adaptation. Stage 3 is unstable early decompensation. Stage 4 is the stable decompensation. Stage 5 is the severe decompensation. These are the 5 stages of beta cell dysfunction. In this slide, the stage 1 means it is increase in insulin secretion results from an increase in beta cell mass. Stage 2, beta cells no longer compensate because normal glucose level can no longer be maintained. Stage 3, unstable transient stage of decompensation. Stage 4, enough insulin secretion to remain in this stage rather than progressing to ketoacidosis. So beta cell mass is reduced to 50%. Stage 5, marked loss of beta cells is and progression to ketotic stage dependent on insulin for survival. So there are multiple mechanisms are responsible for beta cell failures in type 2 diabetes. On the left hand side, you can see incretin impairment, inflammatory cytokines, transcription factor, susceptibility genes. On the right hand side, you can see insulin resistance, amyloid deposition, lipotoxicity, and glucose toxicity. So the potential modulators of beta cell function, that is environmental and genetic, lipotoxicity, and glucotoxicity, the 3 important factors. So if you take the glucotoxicity, what does it does? You can see the chronic hyperglycemia leads to oxidative stress and inflammation and changes in the regulation of gene expression. The uncoupling protein 2 expression in beta cells is increased with the reduction in the ATP ADP ratio, inhibiting glucose stimulated insulin secretion, contributing to diabetes mellitus. Increased reactive oxygen species production from mitochondrial overstimulation and RNS from excess nitric oxide production in beta cells leads to inhibition of electron transport chain, resulting in reduced energy production, DNA damage, and formation of advanced glycation end products. The next aspect is the lipotoxicity. When fatty acid concentrations are elevated, lipid synthesis and storage within the beta cell is favored, and chronic exposure to beta cells to fatty acid excess directly impairs GSSIs. The increased free fatty acid flux to the liver and skeletal muscles leads to increase of fat deposition, decrease of glycogen synthesis, and mitochondrial dysfunction. Insulin resistance in adipocytes eliminate insulin induced repression of lipolysis. So, the prolonged exposure of beta cells to elevated levels of free fatty acid can have many deleterious effects like decreased glucose stimulated insulin secretion, impaired insulin gene expression, increased synthesis of ceramides, upregulation of UCP2, activation of oxidative stress, activation of the unfolded protein response, increased beta cell inflammation, beta cell apoptosis, and increased islet amyloid polypeptide. So there are several genetic and environmental factors. There are several genes are associated with increased risk of developing type 2 diabetes. The genetic variants of genes confer risk of diabetes by interfering with three mechanisms, that is reduction of insulin secretion, impairment in incretin release, impaired pro-insulin to insulin conversion. So the genetic predisposition is associated with an initially beta cell intrinsic defect in case of increased demand, as it is in obesity, and insulin resistance leads to beta cell failure. Next is the environmental factor. A chronic high fat diet leads to insulin resistance by inducing mitochondrial stress and thereby causing diminution in beta cell function. Because this we have to very much understand, ladies and gentlemen, because even in India as well as in Egypt, the consumption of fat is more. So this leads to insulin resistance. We should be very, very careful. So the chronic disuse of muscles decreases mitochondrial content and oxidative capacity, leading to impaired glucose utilization at peripheral sites. So, the poor nutritional status at fetal and infant stage can permanently alter glucose insulin metabolism and increase susceptibility to type 2 diabetes. Protein malnutrition during fetal life resulted in decreased pancreatic beta cells, mtDNA content, impaired beta cell development, and impaired insulin secretion. So, there are several toxic metabolites coming from the environment, such as pollutants or exposure to certain xenobiotics, that lead to decrease in beta cell survival. Among these, the most relevant metabolites are the following, that is the bisphenol A, heavy metal exposure, glucocorticoids, and dioxin. Persistent organic pollutants can increase the activity of glutamic transferases and thereby inhibit mitochondrial oxidative capacity. Next important aspect is the glucotoxicity. There is a strong relationship between the glucotoxicity and the beta cell function. The long term elevated plasma levels of glucose and fatty acids contribute to beta cell decline, a phenomena known as glucolipotoxicity. Hyperglycemia increases melanin CoA levels, leading to decreased oxidation of fatty acids and lipotoxicity. Mechanism proposed for glucolipotoxicity induced beta cell dysfunction includes endoplasmic reticulum stress, mitochondrial dysfunction, and reactive oxygen species production, highlight inflammation, and highlight amyloid polypeptide increasing. So there is a significant relationship between mechanism triggered by glucolipotoxicity, creating thus a vicious cycle that eventually leads to beta cell failure. So the oxidative and endoplasmic reticulum stress plays an important role in beta cell dysfunction. Next important aspect we should know is the autophagy. Autophagy is a conserved and a physiological defense mechanism against acute stress that maintains cellular quality control by removing protein aggregates and damaged organelles, and acts as an essential process for maintaining cellular homeostasis. So the oxidative stress is able to affect mitochondria and generate a higher amount of reactive oxygen species because of the impairment in the antioxidant defenses, leading to mitochondrial dysfunction and pancreatic beta cell failure. So in this slide you can see the mitochondrial dysfunction, how it leads to reactive oxygen production, and it is mitochondrial dysfunction is induced by glucolipotoxicity, plays a pivotal role in beta cell failure, and leads to increased ROS production as a result of metabolic stress. Next is an important aspect, that is the islet inflammation. Exposure to glucolipotoxicity leads to the production of inflammatory cytokines, leading to beta cell dysfunction and apoptosis. So, NFKB mediates direct or through IL-1B, inducing interference with electron transfer and inhibits ATP synthesis in mitochondria, leading to decreased insulin secretion and beta cell function. So, chronic exposure of beta cells to inflammatory cytokines can cause endoplasmic reticular stress. The islet amyloid polypeptide increasing. You can see the amylin or the islet amyloid polypeptide is a 37 amino acid peptide hormone co-secreted with insulin by pancreatic beta cell in response to nutrients including glucose, lipids, or amino acid. So aggregated islet amyloid polypeptide, that is IAPP, is a pathogenic feature of type 2 diabetes. In this slide, you can see the histopathological features. IAPP is normally secreted by beta cell and has a regulatory function. Aggregated IAPP, that is islet amyloid polypeptide, is cytotoxic. Both intracellular and extracellular aggregates of IAPP are found in type 2 diabetes. So the precursor and intermittent forms of IAPP increased after prolonged exposure to high glucose. Amyloid aggregates composed of amylin accumulates in the beta cell, causing the dysfunction of cell membrane, inflammasome activation, mitochondrial damage, and ER-induced apoptosis. So glucolipotoxicity causes increased insulin requirement, leading to increased production of both insulin and amylin. Highlight amyloid polypeptide inhibits the first and second phase of glucose stimulated insulin secretion. So this is a pictorial development. I'm sure all of are aware how the over a period of time the beta cell dysfunction progresses once the patient has developed type 2 diabetes. So there are clinical predictors of beta cell function like HOMA model, that is homeostasis model assessment, pro-insulin ratio, and most important, the measurement of C-peptide. So this has an implication for treatment. So preservation of beta cell mass is crucial for islets to maintain normal glucose concentration in the face of increasing glycemia and decreasing insulin sensitivity. So the use of so many drugs like sulfonylureas, thiazolidinones, insulin, GLP-1 RAs depends upon the beta cell mass. So the anti-diabetic therapies can have both direct and indirect effects on beta cell mass, as we know, with regards to glitazones, incretin therapy, glimins, insulin, metformin. This is direct effects. Indirect effects are metformin, glitazone, incretin therapy, sulfonylureas, SGLT2 inhibitors. So there are several trials evaluating novel agents for the restoration of beta cell functions like anakinra, ghrelin, cyanogliatin, and zenin. So these are the future molecule which are coming up, which helps in the restoration of beta cell function. There are several techniques are in the development of restoration of beta cell mass, like beta cell restoration, like beta cell replacement, with the prevention of autoimmune response in type 1 diabetes necessary, transplantation of human islets or intact pancreas, and transdifferentiation. There is the beta cell regeneration like neogenesis and proliferation. So are beta cell regenerated from replication or neogenesis? So you can see in this slide, stimuli for regeneration should also be there, and response to stimuli should also be assessed. So beta cell regenerate from alpha cells in animal models with extreme injury. There are studies which shows that insulin in increase producing beta cells and decrease in glucagon producing alpha cells. So, take home message from my talk, ladies and gentlemen. Several factors may have a bearing on beta cell, including lifestyle, clinical, and metabolic factors, as well as ongoing therapies. The early identification of these clinical predictor could provide clues to developing strategies to ameliorate the long term management. On the right hand side, you can see the simple graph which shows how the environmental plays a role in developing insulin resistance, increased metabolic load, and systemic inflammation, leading to genetic susceptibility, highlight response, decreased beta cell function and mass, ultimately leading to type 2 diabetes. So, final summary. Beta cells are maintained through a delicate balance between cell loss and cell regeneration. Beta cell failure has a fundamental role in pathogenesis of both type 1 and type 2 diabetes. Surrogate markers are used to evaluate beta cell function in patients with diabetes. The pathogenesis of type 1 diabetes involves cell mediated autoimmune restriction of the beta cells. Patients with type 1 diabetes remain some functional beta cells at diagnosis and long after. Reduced beta cell function and mass begins at an early stage in diabetes. Several mechanisms are responsible for beta cell dysfunction. Strategies to ameliorate the autoimmune response in type 2 diabetes include primary and secondary prevention and interventional immunological techniques. Therapies to restore beta cell mass are in development and include stem cell replacement and regeneration techniques. Several pharmacological therapies are available for the treatment of type 2 diabetes that may help to preserve beta cell function. Thank you for your patience hearing. Once again, I wholeheartedly thank Professor Noseh Yusuf and the whole Egyptian team for making me a part of this wonderfully organized conference. Good wishes for the conference. Namaste and take care from Dr. Aravind from Bangalore. Good wishes from India. Wish you all the best. Take care. Thank you so much.